I think that there certainly may be scenarios that just you have to have the documentation to back it up. Whether you had a patient that was getting injections in both eyes, they're coming in this time because of new symptoms of X, Y, or Z, and you're looking for it and you identify something totally different. That might be a scenario that applies. But again, it really goes back to having a chief complaint, supporting the need for that additional investigation, that exam. But just know that the bar is going to be much, much higher, and your documentation really needs to meet that level to kind of pass audits, which are, as we know, increasing in frequency in an area that's kind of had poor audit failure or audit pass rates in the past.
Yeah, and I would just add to, when we're thinking about bilateral injections, and sometimes when we provide external chart audits or our consulting services, we might see chart records with bilateral injections. And the practice is billing with modifier 25, and they're pointing to some of the procedures, or excuse me, the diagnoses or the problem list. But oftentimes these diagnoses aren't really assessed at the encounter today, whether it's a PVD or a cataract with no changes at all. It's not noted in the chief complaint. It's clone documentation from previous visits. That's going to be really, really hard to defend that that's really the significant separately identifiable reason. Now, but Dr. Shah, what are your thoughts? Of course, if something like a new diagnosis, on the OCT today, you note that the patient has a brand new macular hole. Well, this is a new diagnosis. This is significant, separately identifiable. And I'm sure you see other scenarios in your practice where this is something new. Or what about a significant change in the patient's vision related to that cataract?
No, exactly. I think we were just talking earlier about bilateral injections, and if you have a patient with poor vision, you're doing the injections, everything looks fine on your scans. You still have to explain the loss of vision. You do the dilated exam, you find the cataract has progressed significantly. It's now at a point where interfering with your ability to provide care, patient's vision, et cetera. Now you're recommending kind of an evaluation for possible surgery, that type of thing. That change in the exam, those are kind of going to be the more likely ones to succeed in terms of those bilateral injections. But again, having that significant difference is something that you really want to have to identify cases that can kind of stand up to those audits on the bilaterals.